People become infected with the TB germ by inhaling the droplet nuclei. It's really important that the greatest risk factor of developing active TB disease is 2 to 3 years after you inhale the TB. So when you seroconvert from a negative to a positive, your greatest risk is in that first 2 to 3 years. Really important around TB, latent TB infection. It's dormant, it's sleeping, it's actually not a case of TB. What we'd like to do is focus on this side in terms of the take-home message on point 1, latent TB infection. TB bacteria is in the body, the bacteria are inactive, it's latent. In active TB disease, there is bacteria in the body, but the bacteria are active and they're multiplying. So this is the biggest misconception in the field, and not only clients but healthcare workers don't understand the difference. Again, with preventative therapy, we have 9 months of INH and 4 months of rifampin. We're actually in clinical trials nationally to look at the efficacies of the 4 months of rifampin, and it looks like it's just as equivalent. So this is really good news. Again, we're looking at ongoing transmission in the next few slides, so we'll keep going. So when starting medications for active TB, we often start patients on quadruple therapy, wait for sensitivities, and then drop a medication. Again, sensitivities and infectiousness is obtained from your sputum. So really, bird in hand, get a sputum when you can.
Okay, so for the next little bit, we'll talk about the principles of TB infection prevention and control, mostly within facilities. My favorite slide is this one. There's 4 factors that influence the risk of TB transmission within a facility. There are patient-driven factors, diagnostic and lab-driven factors, environmental factors, and treatment factors. When we're talking about patient factors, we're talking about indicators like respiratory disease, the number of patients with respiratory TB disease in the facility, respiratory secretions that are AFB smear positive, the presence of cough, and atypical manifestations of the disease, such as a delayed diagnosis. All of these indicators, if they're present, increase the risk of TB transmission. This also emphasizes the importance of sputum collection and accurate diagnosis, prompt and accurate diagnosis. The second influential factor in TB transmission are diagnostic and lab factors. The performance of cough-inducing procedures, delayed diagnosis, which can be influenced by no sputum collection, no chest x-ray done, improper handling of lab specimen, and autopsy and preparation of pathology specimens. So again, delaying the diagnosis will increase the risk of transmission. The third factor that increases the risk of transmission in TB are environmental. Inadequate ventilation that doesn't remove the airborne droplet nuclei of the TB bacteria, inadequate TB infection prevention and control measures, the duration of the exposure and the proximity of the infectious patients, overcrowding, and the absence of sunlight or UV light. A good example of overcrowding and UV light is in the Kelowna outbreak. There was one of the shelters there that was outfitted with UV lighting at the intake ducts to reduce the spread of the TB bacteria throughout the facility. And just to illustrate, talking about droplet nuclei, obviously the large droplets settle more quickly to the ground, and once they hit a solid surface, those bacteria are dead. It's the smaller droplets that are more dangerous and can suspend in the air for hours. And this illustrates, again, droplet nuclei can travel on air currents and why isolation and negative pressure is so important. The fourth factor that increases the risk of TB transmission are treatment factors: incorrect therapy, ineffective therapy. For example, if someone was started on a therapy and their sensitivity turned out to be showing that they are resistant to, say, INH. If they were taking INH their treatment would be inadequate and they could have still been spreading the disease while on therapy. The absence of therapy, if the patient is non-adherent, and delayed treatment for any reason if they have an elevated AST and treatment ends up having to be held. This delay in the diagnosis also increases the risk of transmission, so always keeping in mind that therapy within a hospital, making sure that treatment is appropriate before you remove isolation. There are some necessary provisions that must be in place within a facility to prevent and control the transmission of TB. There are 3 facets of control that should be present according to the CTS, Chapter 15, sorry. There's the administrative controls, environmental controls, and personal protection controls. Administrative controls are policies or measures that provide overarching protection for all healthcare workers, patients, residents, and visitors. These policies, they allow for the rapid identification, isolation, and treatment of patients with this suspected or confirmed TB disease, the use of appropriate environmental controls, health programs for TB, the use of personal protective equipment, and the provision of education for healthcare workers, which is quite important for frontline workers in terms of identifying symptoms and when to collect sputum and send a patient for a chest x-ray. And if anyone ever needs any assistance in providing education for healthcare workers, TB services is always available for consultation for that. We're happy to help. The second part of control in a facility are environmental. There's environmental measures reduce the likelihood of exposure to viable airborne TB bacteria. So this speaks to the mechanical ventilation systems like HEPA filters and UVGI lighting. Those are very specific specifications that are detailed more in Chapter 15 and are very facility specific and driven. So if you want more information about what your facility should be equipped with, you should probably go to Chapter 15 and discuss it with your supervisors and go forward from there. Right. So measures directed to individual healthcare workers, either to prevent infection or to prevent TB disease if infected. Personal respirators. Respirators are N95s. Those are the most common kinds of respirators. So these are things that will help decrease the spread of transmission from a healthcare worker to a resident or a patient. The detection and treatment of latent TB in healthcare workers is also important, naturally, because we want to prevent a healthcare worker from going from latent infection to active disease. And so that's why occupational health TB programs are important.
So part 3, there's key concepts that we're going to talk about. Basically, the risk of healthcare-associated transmission, TB risk classifications at healthcare settings, high, intermediate, low risk for patient care facility activities, and then patient population TB risks. So that's going to be the next few slides. So in terms of these this number 1 would be the risk of healthcare-associated transmission. So if you are kind of working in the ER or in the ICU, if you're, in terms of the occupational group, if you're a respiratory therapy and you're inducing sputum, or you're doing a procedure that will aerosolize the droplet nuclei, you're at greater risk. So the patient resident population, so if you're working with populations that are at higher risk, we will go through some subsets of these populations. So think TB, and looking at what you're doing may increase your risk of transmission. So this is a very new slide, hence the new adaptation of the bullet there. This table speaks to the risk of transmission in relation to active TB cases and the number of beds in hospitals. This previously was the risk group category. It used to be record low and medium. So note that the category of not considered low was previously referred to as medium risk. Again, as Michelle has alluded to, refer to the CTS edition 7, the chapter 15 for details, just to let you know that this is worded differently and it's different to what you normally see in terms of low to medium. If we look at, this is the point 3, the patient activities which are associated to varying degrees of risk, and we're going to go through that. So again, these are from the edition 7. So if you're doing inducing procedures on like sputum induction, that's going to increase your risk. These are high risk. So, if you're doing bronchoscopy, if you're working in a lab with, you're doing the sputums and you're working with cultures. So those are high risk occupations that will increase your risk. These are intermediate risks. The work that, if a nurse is working on ward where there are TB patients who have respiratory TB patients, so you're at intermediate risk. Healthcare workers that are working in pediatric units with patients who are admitted who have TB, so that would make you at intermediate risk. Low risk, if you're clerical, reception, admin staff, you're at a low risk category. And so now we're going to look at the activities on how do patients population patients and their factors that influence increased risk for TB. And so those historically those with a history of TB. So if they weren't previously treated, staff or residents of a homeless shelter, as Michelle alluded to earlier, the urban poor, either the downtown east side, persons from First Nations communities who live off and on. If we go further down, it does say Aboriginal Canadians residing in communities with high rates. Although being Aboriginal is not a risk factor, it's the social determinants of health that kind of impact your risk. So it's really important to look at where people are from and the history of whether they've been around TB. If we continue, people infected with HIV, that's one of the highest risks that we have for breaking down with TB. Elderly people, and then those born from a previous country, those countries which have higher incidence rates like Asia, Eastern Europe, Africa, Latin America. So it's really important to know who you're working with. So the most important element of TB management, the TB management program is the rapid diagnosis, isolation, and the start of patients with respiratory TB. This was a really interesting fact. Delayed diagnosis occurs in almost half of all hospitalized patients who have respiratory TB. And so there's almost half of the patients that are diagnosed, there's a delay. I think it's really interesting.
Okay, thanks, Nash. For the next little bit, we'll talk about some key practices, things that you as practitioners can do to help prevent the spread of TB in your facility. The first thing to know and to do is the concomitant respiratory TB disease should be ruled out in cases of non-respiratory TB. So if you've got somebody with TB lymph, you should be making sure that sputum is collected. Thank you. Make sure that sputum is collected from that patient as soon as possible. Again, prompt diagnosis to reduce the transmission of TB. The second thing you can do, if you have a patient who has had a cough for more than 3 weeks duration with or without weight loss and fever, and they belong to one of the risk groups that Nash just outlined, you should be thinking of a prompt and thorough investigation to determine whether active respiratory TB is the cause. So if you've got a patient who is from one of those high-risk groups who is presenting with the symptoms that we talked about earlier, you immediately should be thinking TB. And if you're thinking TB, you should be collecting sputum. At least 1 stat sputum, 3 is ideal. It's not unreasonable to also do a TB skin test, but keeping in mind that in about 30% of the patients with active TB, their TB skin test will be negative. It's not diagnostic for active TB. The third thing that you can do, patients, including any children of any age who show signs and symptoms of TB or whose respiratory secretions are AFB positive or whose chest x-rays are suspicious, they should be put on airborne precautions until respiratory TB is ruled out. Again, by collecting sputum. That's really the only way to rule it out.
And really thinking TB.
Is the sputum collection. So if your facility does not have adequate a negative pressure room, the patient should be placed in a single room with the door closed and a portable air filtration unit used in place until they are transferred to a facility with adequate airborne isolation facilities. Airborne precautions also include the use of respirators by healthcare workers caring for patients with suspected or confirmed active TB. So even if you're suspecting TB and it hasn't been confirmed, that patient should be isolated and healthcare workers should be wearing N95s when they're dealing with that patient. Key practice number 4, masks should be used by patients and residents with suspected or confirmed respiratory TB when they're outside their room, their isolation room. It's the patients who wear the surgical or the procedural masks, not the N95. So sometimes people think that these N95s are better masks. In fact, they're designed differently. So the surgical mask is placed on the patient. It's a physical barrier, and it traps the droplet nuclei from escaping into the air. And it should be worn whenever that patient leaves their isolation. This surgical procedure mask is not effective in protecting a healthcare worker from inhaling the TB bacteria. So while it prevents the bacteria from getting out into the air, it does not prevent the healthcare worker from inhaling it in. So surgical masks are for the patient. It's also important with a patient, even on isolation, to encourage them to cover their cough with a tissue. It reduces the droplet concentration in their room, and to remind them to use surgical masks when they're outside. It's also kind of important to keep in mind to keep tissues available in their rooms and wherever patients are gathering, so that they have tissues available for them, and to remind them to dispose of their tissues appropriately. And then, so prevention or protection of healthcare workers, we're talking about respirators or N95s. They're the most commonly used respirators for protection of healthcare workers, and they prevent the inhalation of aerosols containing infectious microorganisms, not just TB. They should be used by healthcare workers providing care to or transporting patients with suspected or confirmed respiratory TB. So again, if somebody's being transported from your facility and they're even suspected for TB, that patient should be wearing a surgical mask, and that those healthcare workers should be wearing N95s. And here's some things that look familiar to you all, I'm sure. These are N95s.
Can you pick the one that fits your mask?
That fits your face? An important part and a key practice also is, as part of protecting or preventing the spread of TB in your facility, is fit testing and seal checking. Fit testing is used to determine whether a particular size and model of respirator fits appropriately, so fits around your face. Healthcare workers, you should all be referring to your jurisdictional requirements for fit testing. Every jurisdiction and sometimes each facility has its own requirements. TB Control doesn't manage or monitor fit testing. So each facility will have its own frequency and fit testing process. Once you're fit tested, and every time you use an N95, you should be doing a seal check to make sure that there's a nice tight seal all the way around your face, and no air should be coming into or out of your out the sides of the mask.
It's interesting to note that men who have beards cannot use N95s.
You just can't get a good seal. So during transport, as I said, I just said this, during transport to and from the patient's isolation room, whether they're suspected or confirmed respiratory TB, they should be wearing a mask, and all healthcare workers involved should be wearing their N95s until TB is ruled out. And then once airborne precautions are initiated, the patient should remain on isolation until it's discontinued by designated medical personnel.
So see the CTS 7 for detailed recommendations on discontinuing isolation.
It is, and it is quite detailed, and often I get calls from infection control practitioners to discuss that and to get sort of guidance on that. And again, we're always happy to help. We're not ever going to just refer you to the CTS. Please call us and talk about patient-specific context, because every time it's going to be different and everyone's going to have a nuance. Some of the criteria do include establishment of an alternative diagnosis, clinical improvement with treatment, so that could be viewed by their symptoms have lessened, there's radiologic improvement on their chest x-ray, they've adhered to the therapy that is adequate for them, their sputum converts from AFP positive to negative, or their culture actually comes back from positive to now negative. Their sensitivities indicate full sensitivity to the organism, or there's a low clinical suspicion for drug resistance, so the patient is not, they're not suspected that they've been exposed to an organism that could be multi-drug resistant. And our last, did you know, patients with suspected or confirmed respiratory TB should not share rooms with each other, as their strains and levels of infectivity could be different. So don't bunk two people with suspected TB together because you don't have enough isolation rooms. It's a terrible idea.
So part 5, supporting patients on home isolation. Really important stuff, and in terms of the establishing clear guidelines, we want to make sure that these are communicated to the patient or the client, that there's no non-essential visitors, no essential travel, no use of public transport. It's really important that you have roles and responsibilities in terms of the management of TB in community. The patient then has roles and responsibilities for being on home isolation. So knowledge is power, people, and people need to know what they need, what they can and cannot do. So prior to discharging from hospital to community, ensure that there's a good supply of surgical masks. And so then you're already decreasing that kind of stress. And then identify personal and service needs for that particular patients. In the program that I'm in, the TB Services for Aboriginal Communities, we really use incentives and enablers to support the adherence and compliance. And although those are really great to support the patient, the trusting, non-judgmental relationship that the nurse develops with that patient is key. And visiting patients on home isolation. As Michelle has alluded to, wear an N95 respirator. Patients has a surgical mask, and then obviously if they don't have it, bring supply with you. Ask patients to cover and cough. Obviously, cover their cough and sneezes during the visit, and increase ventilations as much as possible. Open windows, doors, and given the obviously weather outside in some communities, that may not be possible. So safe collection of sputum specimens for patients on home isolation. It's having patients collecting the sputum specimens in advance. So making sure that you're providing them with the bottles prior to your visit, really important. And one of the biggest things that we see in our lab at BC-CBC is that the sputums are not properly labeled, or they leak in transport, and so that the patient has done their job. They've given you some sputums. Maybe they were inappropriately labeled. The biggest thing we do see is that they leak. So please ensure that that's been taken care of, and then you can actually hopefully get that person off of home isolations once they've produced that sputum. And the last point, producing and collecting specimens outside reduce the indoor concentration of the droplet, or having that patient go to their bathroom and do that with the window open. Really important.
So finally, to sort of wrap up a little bit, we'll take some questions later, but there were some, I feel a lot of calls from infection control and occupational health, and I thought I'd bring forward 4 of the most common questions that I get. I spoke with Dr. Jay Johnston, one of our TB docs, and he's provided some answers to 4 of your most common questions. The first question was, how do we address isolation for patients that are being queried for non-respiratory TB? For example, they have no respiratory symptoms. So his answer is that if there are no respiratory symptoms, if the chest x-ray is normal and the treating physicians have no reason to think they have respiratory TB, you don't need to isolate that patient. So if you've got somebody with a TB lymph and nothing else is pointing towards respiratory and TB, then Dr. Johnston has advised that you don't need to isolate that patient just because they've been diagnosed with TB lymph. A second question, if the patient does not have a cough, should the physician be ordering induced sputums, or is a bronchoscopy bronch wash enough? So Dr. Johnston's answer is that induced sputums and bronch washes are equally sensitive. Of course, the induced sputum poses much less risk to the patient and is typically much easier to accomplish than a bronchoscopy. Sputum collection is difficult sometimes for a lot of reasons, and a question posed involved collecting gastric washings from adults. His very simple answer was no, it's just not done in adults. It's reserved for children. And then a second part of that same question involved the collection of sputum samples and the timing. The CTS refers to them being 1 hour apart. And that is what the CTS says. BC-CDC, we're still doing lit reviews on whether that's a practice we're going to adapt.
Okay.
Right now, we're still 8 hours apart, 3 samples, 3 hours apart. So continue collecting 3 samples, 8 hours apart, understanding that we may change our guidelines depending on our research. The final question, a TB patient has been on treatment for, say, 2 or 3 weeks, and the sputum is still AFB positive. At what point can we consider these may be dead cells? Dr. Johnston's answer is that if a smear is continuing to be positive regardless of treatment, the patient should still be considered infectious until that specific specimen converts to a negative culture. So it's the only time we can ever say with certainty that yes, okay, it's a +2 AFB, but it's culture negative. We can safely say that those are dead bugs. So the simple answer is, if they're smear positive, regardless of how long they've been on treatment, consider them infectious.
Great. And just before giving it over to Vida, our partner in BC Lung, who's going to be talking about TB and smoking cessation, just to remember to stay online because we have a number of questions that we will be answering afterwards. So one of the things that have come through online is, what does AIIR stand for? That's Airborne Infection Isolation Room. And then the other question is, when do you label a patient uninfectious or non-infection after initiation of TB treatment? I think Michelle has answered that, but we usually use that they're non-infectious as a title. And we try not to label patients, but I think that was the question, and if I didn't get that, please reiterate it on an email. So we're going to move over to Vida at BC Lung, and she's going to talk for 5 minutes, and then we'll answer some of the online questions. So please stay on the line.
Good afternoon, people. It is my job as the Tobacco Education Coordinator for the Lung Association to hammer home a point, which is that there are synergies that exist. Where are my slides? This one? That one. Okay.
Try it again.
There we go. So the definition of synergy, just in case you don't know, the interaction of elements that when combined produce a total effect that is greater than the sum of the individual elements, contributions, etc., or synergism. In physiology, medicine, or a medical definition, the cooperative action of 2 or more muscles, nerves, or the like. In biochemistry, pharmacology, the cooperative action of 2 or more stimuli or drugs, and certainly these apply to tuberculosis, latent TB infection, and smoking. So I should slow down my speech. Here we go. So if we look at the synergism between tuberculosis and tobacco use in prevention, it's really important to have screening for tuberculosis in the foreign-born, preferably before they immigrate and when they immigrate and arrive, and make sure that you are cognizant of when they convert, if they convert. Aboriginal communities that have a proven history of high risk, partly due to their social determinants of health, the homeless, again, social determinants of health, and people with comorbidities. As Nash said, knowledge is key. So if people are aware, they know the risks involved, they know the signs and symptoms, when they should report, when they should seek help, it is key. Educate your clients, educate healthcare workers, and we can go very much farther in terms of prevention. Tuberculosis in Canada is a lesser problem than it is in high-burden countries, mostly because we have living conditions that are somewhat better than in those countries, and generally improved nutrition also is really important in preventing tuberculosis. In facilities, follow the established infection control policies and procedures, and let's have latent TB infection stay latent and not become active disease. Preventing tobacco use, really pretty easy. Don't ever start. Our role as practitioners is to be exemplars. If children don't see people smoking, they don't see it as normal, so they're less likely to take it up. People need to be informed consumers, so everybody needs to be aware that tobacco is possibly the most dangerous product available for sale on the planet. Regulations play a role in preventing tobacco use and its synergistic effect on tuberculosis, where and when people can smoke make a huge difference to denormalizing tobacco and also to whether or not people are likely to decide they want to quit smoking. It is estimated that up to 16% of tuberculosis can be solely attributed to tobacco use. So if we look at prevention of tobacco use, then perhaps we look at preventing 16% of tuberculosis happening globally, which is never a bad thing. In care and control, the synergism exists for tuberculosis in contact tracing. Make sure you can identify the strain of tuberculosis that is the problem. Make your sputum collections. Make sure you understand the locations, who you're dealing with, where they're from. Medications, follow them, take them all. The synergy with tobacco here is that it may reduce the dose if people don't smoke. It may reduce the side effects. Please consider comorbidities when you're looking at tuberculosis. It's estimated that up to 54% of HIV positive clients are smokers, as opposed to 18% in the general population. COPD is probably not the most common comorbidity, but it does exist. Just because they have a productive cough doesn't mean they have TB. Maybe they've got COPD. If they're a diabetic, circulatory problems are always an issue, and if they smoke, it is aggravated. Again, infection control procedures, treat latent TB in healthcare workers, it's important. So what we have with tobacco, if you use tobacco, it doubles the risk of dying from tuberculosis. Secondhand smoke increases the risk of developing active TB by a factor of 3. The risk of developing pneumonia or influenza or meningococcal meningitis as a complication are higher if there is tobacco use. And if alcohol is included, then it again increases the risk exponentially. Cessation, it's important. If people with active TB disease are likely to quit smoking, then they will probably have a reduced cough, which has got to make treatment a little easier. And it also makes them more receptive to other lifestyle changes. Quitting smoking, single most important step that anyone can do to improve their health. The benefits are, again, pretty standard in terms of health, pretty obvious. Social, no more going outside in whatever kind of weather, be it cold or wet. You get to stay indoors and actually participate in whatever social activities are going on in your life. And the financial benefits, the average Canadian smoker spends about $2,700 a year on tobacco products. So quitting has that fairly immediate effect on your wallet, which is always a good thing. So how can this affect your practice? Well, again, just because they have a productive cough doesn't mean they have TB. Perhaps they have chronic obstructive pulmonary disease. So clients expect to be asked about tobacco use every time you see them. They are 17 times more likely to stop smoking with a brief intervention, and it can be so brief. Ask, do they use tobacco? Have they considered quitting? Advise them to quit and assist them where you can. So let them know that the province operates a plan that provides them with 12 weeks of free nicotine replacement once a year. It is available by phoning 811. Quit Now is available online, by phone, by text, and is a self-help program that's really quite useful. Champix and Zyban, medications available by prescription, are covered by Pharmacare now. So all of these things can double or even triple a person's chances of successfully stopping smoking, and no one is sorry that they quit, ever. So if you have questions, call me here at the Lung Association, or we'll answer them now. Thank you.
Thank you very much, Rita. That was excellent. I was just out for a smoke. No, I'm kidding. So thank you very much. We just have some questions that we have. We're asking for you to actually send us more questions. Michelle's going to take the first question here.
Sure. Someone asked, whose decision is it to stop isolation? Is it a nursing decision? It is actually not a nursing decision. It is a decision made by typically the medical microbiologist of the facility in conjunction with infection control and the most responsible physician. It is neither TB control nor an infection control nurse by herself or himself to decide whether or not to discontinue isolation. So if the question is being posed to you as an infection control practitioner by a physician, you put it back on the physician and consult with your medical microbiologist. Of course, we're always here to talk to you about the pros and cons of isolation, and then again the nuances and context of the patient. But ultimately the decision lies with the facility and with the medical microbiologist and the doctor taking care of the patient. So I hope that answers that question adequately.
Do you want to? Yeah, and so we're going to ask you to take this time now to give us any ideas for future webinars or future sessions that may help you in your work. So please email us or contact Michelle or myself. And then there's an evaluation as part of this. We're going to see if we've got any more questions, and then go from there. I'm going to give you a couple minutes, but just to remember that the CTS is out. They're adapting it. It was in pre-release in July. There's sections of it that are still under draft. It will be available on the PHAC website. We certainly can make it available. We will have it on our website when it's finalized, when it's no longer in draft. There's another question that Michelle's going to grab.
Oh, maybe it's bigger though.
Maybe make that bigger. Can you read the question?
I'll read it. Just hold on. Oh, here we go. Okay, there was a question, I think, from Jennifer. Will the prescription of a 4-month rifampin regimen increase once studies are completed to indicate that it is as effective as isoniazid?
So with our clinical trials, we're actually doing clinical trials for the last 4 years for this phase. We've done obviously a few years before as well for the concurrent phases, but it's looking like it's very comparable. hepatotoxic reactions are similar. The effectiveness of killing the TB germ is similar to INH, and so that will be coming out. We're doing one more year of the study, and again, it's national as well. So, and it said indicate if it's as effective. It's looking like it is as effective, and I think once that happens, in terms of increasing rifampin uptake of preventative therapy, 4 months is so much easier than 9 months. And the other thing about rifampin, it has counterindications with other medications. So if you're on antiretrovirals and you're on an NRT, it reduces the absorption of it. If you're on methadone, so it depends on that patient profile as well. But all else remaining equal, the 4 months has worked. And within the Kelowna outbreak, which has a resistance, low-level resistance to INH, we've used rifampin quite effectively, and it's been great. So I think it will. I think the uptake will increase.
No, but prescription length won't increase.
Sorry, thank you. The prescription length for the rifampin will not increase. It is a 4-month prescription duration, and that's what is being studied. And it's really great clinical correlation right now that it's similar to 9 months of INH. Next question is AGRA. Due to the cost, how often are you utilizing this? So currently, AGRA is a blood test for the diagnosis of latent TB infection. It's fantastic because of those people who have BCG or some other counterindications. Is that skin test actually? Is that TB skin test actually the TB germ, or is it from the BCG? The AGRA is really a great diagnostics tool to tell us that. And so currently it is not covered under MSP. We have 4 satellite labs in Prince George, Kelowna, Vancouver, and Victoria, and it is under the instruction of TB control physicians to direct that. And in the case of First Nations people living on reserve, the cost of that going to the lab is covered by non-insurable health benefits. We're hoping that due to the cost, how often are we utilizing it? It's a great diagnostic test given if you have positive skin test, you have BCG, we can say that get an AGRA. Outside of that, if you are a contact and you've been in contact with somebody who's had TB, your skin test converts, you're positive, we know that you've actually breathed in the TB germ, so we may not offer AGRA. So hopefully that answers it.
So how often we're using it? It's hard to quantify that. Mm-hmm. It depends on the population of the patients that we're seeing at the time. So I think it's used I think it's used frequently. Like yeah. I think on a daily basis we're probably yes. getting. One of our clinic nurses would be able to answer better, but I'm going to say our IGRA appointments are probably full every day. They're using IGRA I would say frequently.
And certainly in the satellite labs, you would go through TB control to get, or TB services to get that requisition sent to the lab. So it is fairly frequent. We don't have numbers. The cost is they're still sending the lab is still sending that blood sample to BC CDC to process. So there is an increased cost.
The patient doesn't pay for it, though.
No. Are there any other questions, any other concerns regarding any of the webinars that we can clear up? As we've indicated previously, that we at TB services are always available on the phone line, so please let us know if there are questions and what you would like us to do to increase your capacity to be able to stop TB in your communities. We have another question. If someone is re-exposed to an active case of TB after completing treatment for latent TB, can they be reinfected? What is the chance that they would be retreatment? That's a good that's a good question. So you breathed in the TB germ. We've offered you preventative therapy. You've taken it. You've had great adherence because you've done directly observed therapy, and a healthcare worker has watched you take the pill. So adherence was fantastic. So we know that that TB germ has been killed. You breathe in another TB germ, can you breathe in another TB germ? Yes. Having been on treatment does give you some immunity, but yes, you can breathe in a TB germ, and depending on the context, the degree of infectiousness of the patient, the environment, the context of the exposure, what's happening with the host, what's happening with the person breathing it in, are they immunosuppressed, has something changed with their medical history, we may. So it's very case dependent. I know, as we've spoken previously, TB is not a black and white disease. It is gradients of gray, so it really depends on the exposure, the environment, what's happening at that particular time. And so we would say that yes, they have been treated. Yes, they can breathe in another TB germ, and they may be treated.
And the degree of immunity is, it's not known how much immunity you would have. We would never rely solely on that in favor of treating somebody. We would most likely treat the person who is re-exposed.
So we just have IGRA testing is done regularly. So yeah, BCG plus a TB positive and low risk of contact. Exactly what. Thank you. This is Cheryl Giffen.
Thank you, Cheryl Giffen.
From our clinic at Vancouver. It's just confirmed that yes, IGRA testing is done regularly at the clinics. It's for people who have BCG, have a positive skin test, and low risk for contact to TB.
Thanks, Cheryl.
All right, is that it? I think we're just going to wait. If we're gonna wait again. And thank you very much for joining us. We really appreciate this. And let us know. Please fill out your evaluations. We're going to give you this extra time to do so during your lunch hour period. All right. Thank you very much, and Happy New Year, guys.
Thank you very much.